Dear friends, dear colleagues, I'm very happy to be today in Sevilla for the UROONCO Congress, and I'm even more happy to have today with us Francesco Soria, one of my good friends in bladder cancer. Thank you, Francesco, to be here.
Thank you to you and to the UROONCO for the invitation.
Yeah, so in UROONCO we are always trying to understand and to push the boundaries, to understand where we have to go. And I'm really happy that you are with us today, because you are really involved in upper tract ureteral carcinoma. And today you gave an amazing talk on distal ureterectomy. Distal ureterectomy is a specific setting for treating upper tract ureteral carcinoma today, and with conservative management in bladder cancer as well as in UTUC, I think it's definitely something that needs more highlights. Please, Francesco, just for at the beginning, tell me the rationale behind distal ureterectomy.
Well, distal ureterectomy, you know, the problem with upper tract ureteral carcinoma that cannot be treated conservatively with an endoscopic manner is that we have to go with RNU. And RNU, of course, causes the loss of renal function. And so probably the main outcome of the distal ureterectomy is to preserve renal function. And why this is important? It's important maybe for two reasons. One, because improved renal functions can also improve overall survival. We have data that patients with a low eGFR after RNU without recurrence go worse compared to those with a good renal function. And
because
also
renal failure,
yeah,
chronic renal failure, okay.
With other cancer and other cause mortality.
Yeah.
And also because improving renal function or preserving renal function may allow for adjuvant therapies. And we know that the main problem in UTUC and with radical surgery is that the majority of patients after RNU are not eligible for cisplatin adjuvant therapy, around 19% if we set the boundaries of 60 milliliter per second of eGFR. But of course, we have to consider that this is good for distal ureterectomy, but we need data that say that distal ureterectomy is not inferior to RNU, especially in high-risk patients, of course.
So let me know, you were talking about distal ureterectomy. Is that the only settings?
Well,
or can we consider ureterectomy, or is it only distal ureterectomy?
No, well, we can just say probably segmental ureterectomy or ureteral resection.
Yeah.
But of course, if you see the literature, the vast majority of the cases are distal ureterectomy. For two reasons, because segmental ureterectomy, not of the distal part of the ureter, requires often an end-to-end anastomosis with a high risk of stenosis, or a ureteral substitution with ileum. That is really a big surgery that maybe we used to perform maybe in imperative cases, also because it's not so common. It's a complex surgery also for the patients with high morbidity. And so the majority is distal ureterectomy with bladder cuff and ureteral reimplantation. I think this is probably the best way to perform distal ureterectomy.
And yeah, do you prefer, let's talk about surgery before we talk about oncological outcomes. Yep. As surgeons, what do you think? What is the best approach to perform a distal ureterectomy? What do we have to do as surgeons? What are your guidelines?
Well, I think that distal ureterectomy requires some important points. When we're talking about urothelial cancer, we have to follow some rules, okay? So not to open the urothelial tract, and so we have, of course, to stay, if possible, extraperitoneal, so in the retroperitoneal space, and this ureterectomy fits perfectly with open surgery, but also, for example, with robotic surgery. Now with the single port approach, you can perform a single port extraperitoneal distal ureterectomy.
Retroperitoneal approach.
And then, of course, you have to perform correctly the bladder cuff. And if you are doing in a high-risk population, you have to perform lymphadenectomy.
Okay.
So I would say choose the approach you want, open lap, robotic, but follow the right oncological principle. Okay, so if your approach does not allow you to perform good lymphadenectomy, maybe change approach and go back to open is okay.
Two other questions, maybe on the surgery before we go back to the outcomes. When you perform your RNU, do you systematically or never or sometimes do endoscopic resection of the bladder cuff? And how do you assess the upper limit of your resection of the ureter with also a frozen margin or not?
This is a very good question. I mean, regarding the bladder cuff approach, we have some, I would say, in contrast data regarding the intravesical, extravesical, or endoscopic approach. Probably we have some insights the endoscopic approach is related with more upper tract recurrence and also in-bladder recurrence. So probably the intravesical, extravesical approach could be probably better, but we have no really prospective data on this. And about frozen section, this is a really good question because this is an important point. I think that frozen section, if possible, should be performed because, of course, this is the surgical margins are one of the most important predictor of recurrence.
Especially if you do a conservative management afterwards. Okay, let's go back to the oncological outcomes. I know mainly it's retrospective studies, small cohort, because anyway it's a niche right now. What are the outcomes? What can you give us as the audience of what are the outcomes of segmental ureterectomy in RNU?
Well, we have a lot of systematic reviews, for example, comparing kidney sparing surgery and also segmental ureterectomy to RNU. But if you look to the studies, you were right. I mean, the majority have retrospective with a high risk of bias. What the meta-analysis says is that there is no real difference between distal or segmental ureterectomy at RNU regarding long-term oncological outcomes. But the majority of the trials is also focusing maybe in a mixed population of low-risk and high-risk disease. If we focus on high-risk disease, because I think this is the more interesting part.
Because this is the part where normally we should do RNU.
RNU, right, because normally now with the improvements of technology, we are treating endoscopically the vast majority of low risk. But if we have some high-risk patient with tumor in the distal ureter, maybe we can refine our selection and maybe propose distal ureterectomy. So in this case, which are the outcomes of high-risk patients treated with distal ureterectomy? Well, we have really some very small retrospective series, around 25 to 30 patients with good median overall survival, around 60 months. And now we are, as you know, we are doing in the guidelines a retrospective multicenter cohort of distal ureterectomy. And what's interesting is that in the majority of the patients were high risk at the beginning, at not low risk. And also in high-risk patients, we have similar outcome compared to low risk regarding intravesical recurrence, ipsilateral upper tract recurrence, and overall survival. The only difference is regarding recurrence-free survival, with high-grade disease being the main predictor of outcome. So maybe we can convey some insights more regarding patient selection to say, okay, some high-risk patients probably we can do conservative management, but probably not in high-grade disease.
Okay. And so what the guideline says today, and what are your input to say, how do I select these patients?
Well, today the guidelines are quite clear, and they say that we can perform segmental ureterectomy in low-risk patients when endoscopically management is not feasible, or in selected high-risk, which is a selection of high-risk, okay, is based on weak and strong criteria. And I would probably say that after also our series, we have maybe some insights more regarding counseling with patients, regarding the need for salvage RNU, regarding the ipsilateral upper tract recurrence. But I would say that we can probably propose to very well-informed patients conservative treatment in non-high grade UTUC. This is probably my feeling.
Okay. I think it's quite clear how we can go now for the indication of segmental ureterectomy. Thank you very much Francesco. Congratulations again for the hard work you did for this paper that will be hopefully published soon on the retrospective multicentric study on distal ureterectomy. I hope that it may help to shape a bit more the guidelines in the coming years. So thank you very much.
Thank you, Benjamin.
It was a pleasure to be with you today. Thank you.
Thank you very much.